Hello and welcome to today's Power of Knowing webinar, The Ever-Changing Needs of Someone with Dementia. Understanding comes from knowing. A dementia diagnosis touches many people's lives and can be overwhelming for the patient, their family, and caregivers. The Dementia Journey is a special three-part Power of Knowing webinar series that will explore the dementia experience from diagnosis through advanced progression of the illness. Wherever a person is along this journey, this series will offer guidance to help parents, patients, and caregivers plan for needs using resources available at each stage of the journey. The Power of Knowing is a free webinar series created by AuthoriCare Collective, a nonprofit organization that empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanow. Risa serves as clinical and community educator at AuthoriCare Collective and is also a member of the Cone Health Ethics Committee. She is a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It is my pleasure to introduce our three panelists for today. First, Dr. Monica Carter. Dr. Carter is a long-term care hospice physician with AuthoriCare Collective. She previously was employed with Piedmont Senior Care and Adult Medicine at Cone Health. Dr. Carter earned her medical degree and completed her residency in internal medicine. She is the oldest of 4 children raised by a single mother. Dr. Carter was the first in her immediate family to go to college. Dr. Carter says it was the show Trapper John MD that first inspired her to become a doctor. Welcome. And Teresa Cooper. Teresa Cooper has been with AuthoriCare Collective for 2 years. After a long career as an elementary school teacher, she obtained her master's degree in Human Services and Social Work. Teresa has been in the healthcare field now for over 10 years, working in long-term care, home health, and hospice. Recently, Teresa added certified dementia coach and certified virtual dementia tour trainer to her resume. And Alexis Williams. Alexis is the executive director of Caregiver Connect, Inc. This organization's mission is to serve family caregivers by providing educational opportunities, encounter support groups, and supportive caregiver navigation. Alexis's previous experiences as a senior advocate, social worker, respite care director, placement specialist, and care manager have been wonderful building blocks for the mission of Caregiver Connect. She's a graduate of Georgia State University with a bachelor's degree in mental health and human services, and she is also a certified senior advisor. Welcome. Thank you to all of our panelists for joining us for this important conversation, and also thank you to the participants. We want to know a bit about you. We would love to know all of the different roles. We know so many of us are juggling many roles, whether it is ourselves as a patient and a caregiver and an advocate. So this is a multiple choice question. Please check all that apply to you. It is anonymous. And we are also interested in knowing whether or not you or someone you care about live with dementia currently. And we know that that can cover people very early in their disease process up through more advanced. So we appreciate everyone answering and taking a moment to reply to the polling question. It gives us not surprisingly, we see a large number of caregivers on this call, many healthcare professionals and advocates. We also see over 70% of people joining us either are living with or caring with someone who does have a dementia diagnosis. So certainly a very appropriate conversation, and thank you for joining us. I want to invite everyone to make use of the Q&A box during our time together. I will acknowledge we may not get to every question. We will do our absolute best to do that. And also, please know that this is being recorded, and an email with links to different resources we may mention will be sent out tomorrow. So know that you'll continue to receive information. But it seems, Dr. Carter, as we start our conversation, when we think about the title for today, the ever-changing needs of someone with dementia, is to really stop and think and learn some about dementia. We know there are many different types. We know that it progresses. Can you tell us things that you want us to know about dementia, how it progresses? What is important for us to know about this?
Thank you, Marisa, for that nice introduction. I would like, there are many different types of dementia, as you all may be aware. There's Alzheimer's dementia, which is the most common. There's also frontotemporal dementia, Lewy body dementia, and vascular dementia, as well as mixed dementia. So on top of all of those, you can have a mix-up of several different ones, two or three of them, mixed into the mixed dementia. The Alzheimer's as being the most common, the thing about that to know is it's a cognitive decline, a gradual one. So we go through different stages and we lose things like the ability to multitask. We lose the ability to dress ourselves and bathe. And we call those activities of daily living things that we start to lose gradually. And it's not for the most part, it's not a sudden decline. It's more of a gradual decline. And we also lose the ability to carry on a conversation. The amount of words that we can use from day-to-day changes, and it can actually get to less than 6 to becoming nonverbal in Alzheimer's. So those are some of the things we can look for. In frontotemporal dementia, the most prevalent thing with that dementia is behavioral and emotional disturbances. So those individuals are usually agitated and don't really. It's very difficult to redirect them to calm down with the frontotemporal dementia. And also the thing about frontotemporal is it occurs usually in those, you can be as young as 45 and diagnosed with frontotemporal dementia. Lewy body dementia is another type of memory loss where you see more visual hallucinations with Lewy body dementia, as well as decreased facial expression. Those are the two most common hallmarks for Lewy body dementia. Vascular dementia, of course, is usually from things that interrupt the vasculature or the blood flow to the brain. So whether that's a stroke or a tumor or anything to that degree, it affects and causes vascular dementia. Usually vascular dementia patients their dementia is hard to categorize like Alzheimer's, definitely, because most times, because it's an interruption of flow of the brain, they will maintain their language center. So they may be able to carry on full conversations, but yet they're forgetting to do simple tasks like turning off the stove or getting dressed, or losing their ability to maintain continence with bladder and bowel. They're misplacing a lot of items usually, but they're walking and usually talking. So that's the biggest thing with vascular dementia. And then mixed dementia, as I stated, can be 2 or 3 or more of the dementias altogether. Those are usually the hallmarks. And the other thing about dementia in general is that you can have some disease states that look like dementia but aren't dementia. Things like if you're, we say delirious, or if you've had a head injury and you have a concussion, that can look like a dementia. Some emotional problems, if they're severe enough, like depression and anxiety, that can also look like dementia. Other disease states that may have a dementia component to it are things like heavy alcohol use over a long time, HIV disease associated dementia. You can have also a chronic encephalopathy, which is like brain damage from traumatic brain injury. Huntington's disease can also present as a dementia, and that's an inherited dementia. Other things like normal pressure hydrocephalus, which is an increase in the brain fluid that moisture, for all intents and purposes, moisturizes the brain. That can also look like a dementia. And even rare types of dementia are like Creutzfeldt-Jakob disease, which is very rare. And those are the most important things that I'll have to say about dementia.
Thank you. And am I correct in saying of each of those dementias that you've just mentioned, they are all progressive, meaning
Yes.
they are going over time to get worse, and the needs of that person will increase, and their overall status is going to not just change, but decline over time.
Yes. And not only that, they can also wax and wane with their decline. So one day they may be fine, and then the next day they have a decline, and then 3 days later they're back to being themselves. So it can wax and wane as well.
So as we're talking today, we are thinking about where we are today, and then we're thinking about this reality of progression. And so, Alexis, I am looking already at the question and answer, and somebody has commented that a 62-year-old sister has just been diagnosed and very angry and doesn't want to have conversation. Somebody else has noted that they're a financial planner, and we know how important that role is for so many people, particularly if they are early in their dementia journey. And so given the work that you do, and we think about the person with dementia, we also think about that caregiver. And what comes to your mind as what I want caregivers for someone with a dementia to know is?
Thank you for this opportunity. And as I was listening with Dr. Carter mentioning all the different types of dementia, the first thing that came to my mind is that if someone has these concerns, it often helps, I think, from what I've seen in the role here at Caregiver Connect, for the caregiver to identify as a family caregiver. So oftentimes I think we go about our relationships as maybe being a daughter to a mom, or being a spouse to a loved one, or being a nephew to an aunt or an auntie. And when we're speaking about dementia specifically, or certain medical conditions, I think it's important to think, I'm also a family caregiver. And the reason for that is, as dementias have become regrettably more common, or we're learning more about them, so people are becoming aware that they have this diagnosis, I think there are opportunities for caregivers and care receivers to learn about the disease or the conditions, to learn about the symptoms, to be better informed, to kind of be more knowledgeable about why the individual who's dealing with the concerns is behaving the way they're behaving, to have a better understanding that maybe they didn't wake up on the wrong side of the bed today, that it's actually because their brain is changing, that due to the changes in the brain, these are the symptoms, these are the behaviors that the person has, that the caregiver is trying to live with and experience and deal with. So I think what I tell people often is I have learned the more informed the family caregiver is, the more they feel confident or better aware of how to go about navigating the path for living with this disease or living with this condition. I think if you can identify as a family caregiver, then you can learn about educational opportunities that are available. It helps you to go to events to see other people who are like yourself who are family caregivers. And I think there's real value in being with other people who are doing and experiencing similar things like yourself as a family caregiver. But then also, I think if you can say, I'm a family caregiver to someone who has a diagnosis of dementia, you can seek out resources that might support you in your caregiving role. And there are more and more resources becoming available. Case in point, the seminar series that we're doing, we are trying to embrace the folks who have these conditions and trying to aid the family caregiver and the care receiver with what they have going on. So in my mind, I think it's important that if you have this diagnosis, that you can become more informed about the diagnosis. You can own that you are, in fact, a caregiver with someone who has this. And if you are the person who has the condition, I do think it's helpful to talk about it, to say that, in fact, yes, I do have these issues. I do have these concerns. I do realize that sometimes it's hard to do that. But then the last thing, I think it's important to be with other people like yourself who have these conditions, to just to kind of cope better and to kind of feel like you're making progress towards what you're trying to achieve.
Yeah, somebody just put in, how can I help the caregiver accept the diagnosis and that he is the caregiver? That just what you're talking about, it really is a shift. I mean, I am still the family member, I am still the spouse, and I now have another role. It doesn't change that I'm still that family member by choice or by blood, but I would imagine identifying as a caregiver, maybe there's some stigma attached to it or some fears or reluctance. But as you say, Alexis, it can open a door to other resources. And do you have any suggestions? I mean, maybe it is reading something or just viewing something like this, the recording of this webinar, or something that lets us begin the process.
I think it's important to try to take advantage of whatever is readily available that is easy for the caregiver to have access to. I know we tease about, we'll just Google it, but if there are opportunities that you can read about the specific diagnosis, that helps. There are large national organizations that have websites that have material that you can call, like the Alzheimer's Association, like the Michael J. Fox Foundation that deals with Parkinson's, but oftentimes they also have folks who have a diagnosis of Parkinson's, perhaps can have dementia. So in my mind, I would go to the larger organizations that might have material to explain the diagnosis. You can certainly go to the library, certainly go to a bookstore. Obviously, you can reach out to Caregiver Connect. Most county senior programs, both in North Carolina, but throughout the nation, oftentimes have county programs that might have libraries or resource rooms that might have material on the specific diagnosis. Certainly, you can ask your primary care provider for information about that. But in my mind, I think it just helps to say, okay, I'm the family caregiver with this. My loved one has this. this is the diagnosis. What can I learn the most, or how can I go about learning the most? For some people like myself, I'm a visual person, so it helps. I YouTube a lot of things. We were mentioning earlier, I'm a long distance caregiver, and my mom has normal pressure hydrocephalus. And it really helped me to see the video that described what procedure she was going to have with her shunt, what her symptoms were going to be post shunt, and then what to look for and how she might react to the surgery. So I think if you can, you have to, in fact, often own that you have this going on. But once you do, I do think there are more resources out there now than ever before. And certainly everyone on this call would be willing to help direct someone to kind of a portal or an information site to help them gain more knowledge on the diagnosis.
Thank you. So Teresa, when we think about that role as a caregiver, many of us have our relationships already established, and we have in our mind, oh, they are doing this to irritate me, or they, have a choice in this. But I know that that is not the case in most situations. When somebody has dementia, their ability is impacted. And how do you help caregivers and professional caregivers really learn that difference between I am behaving this way because I want to versus I am behaving this way because I do not have a choice. It is not in my control at this point.
So when we look at all that we know about dementia, and we know that it's ever changing, and we know that it's impacting certain areas of their brain, when they have a diagnosis of dementia, at least two areas of their brain are going to be impacted. And so it's not only affecting what we see in memory loss and that sort of thing, but it is affecting them physically too. So their eyesight is affected, their hearing is affected, their balance and all of that stuff starts to become affected as well. And usually if you're around a person long enough and you know what their baseline is, you can tell in most cases if they're trying to get over on you or try to manipulate or things like that, versus the disease taking over and what they are and they are not able to do. Unfortunately, we hear this a lot, especially with people with this diagnosis who live in communities where staff are around them, for long periods of time. They're working, 8-10 hour shifts. After a while, they can begin to tell when a patient is really having a symptom that they can't control versus a symptom they can control. And my advice would be that don't think that just because they're doing something that's irritating that they are able to control it. We know that folks with dementia will repeat themselves a lot, and that gets irritating, right? You ask the same question over and over again. But what is it hurting if they ask the question over and over again? It's irritating, yes, but if they can't control it, they can't control it. So it's up to us to be the change. That person is only going to continue to decline, and the disease is only going to continue to progress. They can't control that. So if they can't control that, then who has to be the change? It has to be us that is the change, which requires us to be, more patient and more observant, and to say things maybe over and over again that we would rather not say. It's just, unfortunately, the disease is one of those things that they have no control over. We have no control over. And so we have to control what we can when we can.
That's very well said. And it makes me think, Dr. Carter, about this reality of progression. And can you talk to us a little bit about, I know everybody is an individual, but certain types of dementia may progress differently. And we know that somebody could also have other health issues along with that dementia. But thinking about the course that many people may take, you spoke a little bit about it, but thinking about somebody who's up and walking around at some point may lose the ability to be as mobile, maybe living situation has to be thought about. And then as we continue to progress, that dementia is a terminal illness at some point, and just sharing some about the course that we often see with dementia, recognizing it can be over a many-year period of time.
Yes, absolutely. So each dementia course can be different from the other, but typically the course is usually slow, and it may take years, although sometimes diagnosis is made later than at a late point. They could have had symptoms for years and it just wasn't diagnosed. Um, Usually it progresses from, little things like misplacing items. Then at some point you may lose the ability to dress yourself, take a bath, or you're falling a lot. That's also one of the declines that we see. And the ability to walk may become impaired. You may go from not needing anything to walk to using a cane or a walker itself, sometimes ending up in a wheelchair. That is a possibility. Leaning to the side is also another sign when, and it could be happening when they're sitting in a chair. You could be leaning to the side or leaning forward. All of those things are signs of decline. The ability to speak, how much you're speaking, what you're saying, whether you're making sense when you're speaking, those are all declines. Um, and these are signs that, especially when the speaking becomes impaired, are showing later signs of the dementia progressing and what we call worsening. Um, Other things that we see, not being able to recognize family, um, and not being able to get out of the bed. Those are all signs. When someone becomes bedbound, that's towards the latter part of dementia stages. Not necessarily knocking on the door of death, but just a late sign of dementia when you're not able to get out of the bed anymore. When our loved ones become combative, sometimes you become combative and you don't want anyone to help you change your brief, or to give you personal care, get you dressed, things of that nature, bed baths, those are all signs of decline. And you're absolutely right, Risa, that, I mean, it is it's a terminal illness. And usually when we're not eating as much, those are all clear signs that we're nearing the end of life. When, what we say in hospice is taking bites and sips. When you're not eating a full meal, you're just, taking a nibble of that and a taste of, and a drink of that. Those are all signs. Difficulty swallowing, they're not being able to swallow anymore, pocketing food. When you put food in your loved one's mouth and they just let it come right back out again, not necessarily throwing up, it just falls out. Those are all, end stage signs that we're, seeing at the end of life.
And I know eating is such a basic, meaningful thing for us. And so often with dementia, I know the topic of feeding comes up, and the question of whether a feeding tube is something that is beneficial, but yet that cannot keep the disease from progressing. And that does not really overcome the problems of the dementia and can present its own problems at times. Is that correct?
That is correct. A feeding tube is, although uh, for the immediate moment helps with some nutrition, has its own potential risk, including aspiration, pneumonia, where even though the feeding tube's in the stomach and you're bypassing the swallowing, that if the feeding tube gets blocked, then the food just kind of that's being put in there can just bag up into the esophagus through the valve. It forces way back out, and that person ends up choking on that particular fluid, and then they aspirate it into their lungs. They basically inhale those contents to their lungs, and they get a pneumonia. And then in itself, the feeding tube can repeatedly get dislodged, come out, fall out. And then, you're talking repeated trips to the emergency room. And, an emergency room exposes you to all different types of things anyway. So then you have that risk as well. So a feeding tube is something that has to be carefully discussed with caregivers and family to make sure, that that's something that your loved one wants or would have wanted at the end of their life. We typically, as providers, would like to say that, feed your loved one as much as they want. If they don't want any more, then we don't want to force them to eat. And force is probably not the best word used, but that's the most appropriate word I can think of at this time. I'm saying because people don't want they don't want to feel like they're starving their loved one. And at the end of life, amazingly, the body really doesn't want that food. So it's not asking for it. So if your loved one doesn't eat as much, it's not necessarily a bad thing. It's just the body's starting to shut down the different systems in order to process foods and drinks. So I would say let the loved one eat or drink as much as they like and just leave it at that. That's the best thing.
Yeah. And we know we can't give and don't want to give medical advice, but there's a question about, can speech be affected all of a sudden as a sign of dementia? Even though there are no other symptoms, it has happened suddenly to a family member, but they also have an aneurysm on their brain. So it seems like that's something where exploration of that particular situation is necessary.
Absolutely. That's a discussion that they need to have with their primary care provider. Their concerns about the speech issue, because it could be something completely different.
So Teresa, I was thinking when we were talking about eating and that word force, and we know that you said we need to be the change. And I wonder if you have some ideas, advice. How do I change? Is it I'm going to take 3 deep breaths? To Alexis's point, I'm going to educate myself. In the moment, though, it can be so difficult.
It can be really difficult. And so one of the ways that you can change is to educate yourself. And a great way to educate yourself is to learn some tools to put in your toolbox that you can use with those particular patients when you've run out of patients and you don't know what else to do. I would suggest, if you don't know, her name is Teepa Snow, Teepa Snow, and you can go to her website, which is teepasnow.com. She also has a lot of videos on YouTube. Alexis was talking about watching videos, and that helps me as well because I'm a visual learner. But Teepa Snow is a world-renowned dementia specialist, occupational therapist by trade, who developed a set of skills that she can teach called the positive approach to care. And she has a video on YouTube literally for every single thing you would do for a person, whether it's getting them to go with you, getting them to brush their teeth or do activities of daily living, getting them to just behave, I guess. In retrospect, you're talking about behaviors and things like that when people's diseases start to progress. And so there's a whole list of things that you could be trying to get someone to do, and I guarantee you she has a video on it online where you could watch and gain strategies on how to handle that particular situation in a positive way, which would make your life easier and make you work a lot smarter instead of harder with regard to a lot of these folks too. Again, I would also suggest, like Alexis said, educating yourself, reaching out to all of these resources that are available today. The Alzheimer's Association has a ton of resources there. You can type in your zip code and you can get particular resources that are that pertain to your particular area that you live in your state. You can go to the Piedmont Triad Regional Council website, which is ptrc.org. There's a ton of support groups there. There's a ton of ideas there for you to use as resources. And if all else fails after all of that, you just have to take a deep breath and call someone to come and help you or sit with you or guide you or that sort of thing. If you can't find resources, like you do kind of with your children, you step away for a minute and you count to 10 and regain your composure and try again. There's no right or wrong answer to it. You have to do what works for you. But just know that you're not alone and that everybody, I think, goes through that is a caregiver. So
thank you. And again, the resources that we're mentioning will be in an email tomorrow. TEPA, SNOW, TEEPA, and then SNOW, SNOW, and that will be included in one of the resources. But Alexis, I'm thinking about this journey, literally this journey, and as a caregiver, as I am educating myself, I want to be preparing myself. We know that feeding, and eating is often an issue. Thinking about where might my loved one live? What are some, buckets or topics of things that I, as a caregiver, want to start really focusing in on? Hopefully sooner rather than later, but we know that we can be at any place in this journey, but sort of thinking, okay, now what should I be focusing on or thinking about?
A great question. I think what I've learned, especially in the last 7 years, is one of the things I tell families is we need to know our insurance policies. So many of us are paying for insurance, whether it's Medicare, whether it's a Medicare Advantage plan, whether it's a secondary insurance, and we don't really know what our policy covers. And sometimes there's support for us within the policy. Sometimes folks have specialized policies that might be a long-term care insurance policy. It might be a special home health policy. I mean, they're all kind of policies. So I often tell people, learn what your insurance is. If you've been paying for that, figure that out and let's see if there's anything within the insurance policy that might support you on this journey, both the caregiver and the patient. The second thing is I tell people we probably need to be thinking about finances. Again, so often folks don't always really kind of know what they have in their budget. They sort of know, but they don't know maybe what's being taken out each month, why it's being taken out. They might forget what's being taken out. They haven't told anyone else other than maybe themselves or their loved one what we have to work with financially. And I really think it's smart to kind of have a really good picture of what your finances are. And then like the third thing that I know everybody on the call has talked about the importance of legal paperwork. And when I say legal paperwork, like, do you have a POA? What type of power of attorney do you have? Do you have a medical power of attorney? Do you have a general power of attorney? Do you have a financial power of attorney? Do you have a will? Do you have an advance directive? I often tell people, let's start with just those three things, to kind of think about the future. So we want to know our insurance, we want to know what our budget is, and then we need to have our legal paperwork in order. And on that subject, so oftentimes the people who might be experts in those fields can also provide some guidance for you, about the topic of kind of the future. Again, if you're not really addressing or owning or accepting that you have the diagnosis, sometimes it's hard to kind of act on these things. So maybe you just start with one, and you don't want to be overwhelmed. So we're just going to start on, what is my policy? Do we have life insurance? Do we not have life insurance? What kind of medical insurance do we have? So maybe you simplify your list a little bit, to kind of check things off, so you feel good that you're working on things for the future. I don't know. Does that help answer
No,
your question?
I think so. Particularly, we know that there are so many people who, and there's a question about safety and care. Dr. Carter, we know at some point people cannot be left alone. If I am falling frequently, or if I may leave the stove on, or I may wander out of the house, there is a reality of at some point needing somebody to be physically present, and I am not necessarily available physically, emotionally, financially to be there 24/7. So the different thoughts about care, I mean, somebody needing to have someone with them all of the time occurs at some point for most people with dementia, correct?
That is correct. And it depends on what your level of comfort is. I know some people like to, well, we just get a private caregiver to sit with mom or dad or your loved one. And then you have to decide, are we going to do this for 12 hours or 24 hours? And it also depends on if you're close to your loved one, like meaning like physically close, geographically close. Are you down the street, or are you 3 or 4 states away or across the world? Those all make a big difference on the decision on how to take care of the safety issue. There are skilled nursing facilities if that's something that needs, and skilled is usually those who are bedbound and requires a lot of um, care for their activities of daily living. Those are usually the skilled nursing facilities. And then you have the assisted living, where if your loved one can do some things by themselves, they need that extra help with their medications, or they might need some help with their assisted daily livings, but typically they're okay. Or, sometimes you need a memory care unit or a lockdown unit, especially if your loved one is wandering. You want them to be in a lockdown facility where the doors are locked and that, the staff is watching them. Did that kind of answer your question?
Yeah, and there's a question, and I think there isn't the perfect answer because you've been speaking to it, which is there an advantage aside from cost to care in a facility versus care at home? Now, of course, care in the home, if you're paying privately, is very expensive, unless perhaps there's a veterans program or other assistance. And care in facilities can be excellent and sometimes necessary, but Dr. Carter, I can imagine you get asked this. You work in long-term care facilities a lot. I don't know one is better than the other versus the particular needs of the person.
That is correct. It again depends on the comfort level of the family and of the patient. It plays a little bit to cost as well, because skilled nursing facilities are typically pretty expensive depending on where you go. And that's when the long-term care policy, insurance policies come in handy, as well as the insurance of the loved one. Like, do they have straight Medicare? Do they have Medicaid? Do they have an Advantage program? All of that plays a role as to where you would decide to go.
And we know that in terms of making those legal documents and decisions, if we can do that, if the person can do that for themselves while they can still make their own decisions, of course, we want to be able to do that. We know, unfortunately, so many people lose the ability to make decisions before they've completed some of that, which admittedly can make things more difficult. But I know that sometimes we turn to our estate planners, or we turn to financial planners, legal aid, and some other resources. But Teresa, when we think about trying to stay in the home, for many people that is highly desirable. And when it's possible, I know that things such as accommodation in the home. Tell us some about things that people might think about. I mean, we have to think about removing car keys, or putting perhaps a different lock on the door, or different things to help not just me as the caregiver, but to help ensure the safety, including bringing in help, including things like palliative care, like hospice, to add to that caregiving situation.
Right, yeah. So safety is going to be paramount in everything that you do and every decision that you make, if you're going to try to keep them at home. I mean, there's so many options out there that are available with regard to personal care services, where you can have someone come and sit with them if you're not able to stay the entire day. Those things generally are not covered by your insurance. They're usually private pay unless you have some VA benefits or some long-term care insurance. And there are a couple of the managed care policies that offer some options with regard to personal care services. But there are also some other agencies out there that are agencies that do services with regard to evaluations and going into a home and assessing the needs. Now, those agencies probably are going to charge a one-time fee where they will come out and assess the situation, look at what you have going on in your home, what you need to remove, what you need to add. Do you need a wheelchair ramp? Should that rug really be there? Those kinds of things. And a lot of times those people that are coming out and doing some of those assessments have like therapists on staff that will evaluate certain situations where you can look and see what's safe and what's not safe. And then, you know, of course, you have other resources too. Like with us, we offer palliative care at AuthoriCare, which is a nurse practitioner and a social worker that are going to come to where that patient lives, whether that's in a facility or in a home, and provide services and an extra layer of support and communicate with doctors and make sure that that patient is getting everything that they need. And one of our new services, of course, is going to be the GUIDE program, which we're going to talk about more, I think, on the next session, if I'm correct, Teresa, and what that is and looks like. And that is strictly for dementia patients living in the home or in assisted living or memory care. Folks that are currently in long-term care facilities would not qualify for that program simply because they already get 24-hour-a-day, 7-day-a-week care. And then later, of course, if the disease begins to progress, we offer the hospice services as well that will follow that patient. And if they are palliative care, the transition to hospice is much easier with us because you've already established that relationship with our organization. And I mean, really, there's so much out there, and I hate to tell people to Google things, but Google is a big help in situations like this, like Alexis said. But if you have any other questions, I'm always available to talk or help. Anyone that has a question, feel free to email me or call me. And if I don't know the answer, I will certainly try to point you in the right direction.
Thank you. And Alexis, I'm thinking about that. Number one, as a caregiver, it can be socially isolating and it can be overwhelming. And you spoke about connecting. And of course, when we connect, there's the supportive benefit, but there's also, we get information. Oh, you did that? Oh, tell me about that resource. And I'm wondering if you could talk to us a little bit about, I know there is not one, obviously, there is no one resource, but things that you think of, support groups. I know there are different blogs associated with different organizations. What are some things that you have heard from caregivers that they find to be particularly helpful during this time?
We are in Greensboro, North Carolina, and one of the organizations that I hear a lot of great things about is Duke Dementia Family Support out of Durham, both with their website, and they have a host of different online events, but then also online support groups and then in-person support groups. Certainly here in our area, we, as Teresa mentioned, I'd be happy to direct people to specific like adult day health programs or respite care programs that might exist. I think those are really important. There are several organizations now that are trying to address maybe caregiving for working caregivers. So there are like workingcaregiver.com or there's one called daughterhood.org, and they have a host of different information on the website, but then have a tab maybe for resources that could be helpful to the caregiver. I think what I always remind people to not forget about maybe employee assistant programs, that maybe if you're still working, that your EAP might have some connections to support you as a family caregiver, might offer some time off, might offer payment for therapy or behavioral health appointments. So don't forget where you've worked, maybe as a possible resource. And then also, too, I'm seeing that several entities that maybe are within the HR department from where the loved one maybe have retired from. So, for example, if you were a federal retired employee, maybe through their HR department, they are offering more support for people with dementia, for caregivers with dementia. So maybe do a little more digging with regards to entities that could be supportive to you that are already in your life. You just haven't thought to ask those questions. Are you doing anything to support the caregiver? Are you doing anything to help support me with this diagnosis?
That's great. There's a question, Dr. Carter, that came in early, and I want to make sure we address it because it's specific, but I think maybe speaks to a larger question, which is somebody is asking really about how do they get their provider to listen to what they're saying, right? I am the caregiver. I am observing behaviors. The neurologist, the primary care physician, the provider I am seeing is the expert in the disease. How do I advocate? Do I bring a list of things I observed? How do I help you understand what I am seeing so that you can then help me best understand how to go forward?
I would have to agree with you. When you see your provider or see your loved one's provider, definitely go with them to the appointment. Hopefully, they'll allow you in the room because sometimes they have refused. And in that event, I suggest that you bring a list or send a list or call ahead to the appointment and give the list to the medical assistant. Any of those are all possibilities to get the provider's attention to let them know that, hey, this is what's going on. I have had consults with family members without the patient being there. And that is one way to do it. Have a conversation about your loved one at their provider's office without them there. And that is also a great way to get our attention. And just continue being an advocate, continue, call the office and say, hey, this is what's going on. What do you recommend? Please do all of that. That is the best way to be the advocate, to let us know what's going on.
Thank you. Thank you. And I want to acknowledge this hour has flown by. I want to thank each of you. You have shared invaluable information. Much of what you've mentioned about different resources will be included in the follow-up email. You can respond to that email if you have an additional question. I will try to get it to the right person if I can't answer that question. But I think, again, Teresa and Dr. Carter and Alexis, what I hear is we want to educate ourselves. We want to make use of our resources. And I want to thank you not just for your information, but the passion and the care that you show, not just during this conversation, but I know every day with those that you work with. Please, those of us gathered today, join us again in 2 weeks, and we're going to continue this conversation. So in 2 weeks, we are going to be having 2 panelists. Candace Bowman is specifically going to be talking about a new Medicare program. Teresa mentioned it. It is called GUIDE. It is a Medicare program specifically for those with dementia and their caregivers, and it is guidance for an improved dementia experience. That's what GUIDE stands for. So we will be learning about who qualifies, what does that program offer for those with dementia and their caregivers. We will also be having Gail Scott join us. Gail is the longtime director of social work here at AuthoriCare Collective. We know that the GUIDE program is a wonderful addition as a service, and people need services that go above and beyond that GUIDE program. And so we're going to be talking about different resources and different services that are available, so that people understand where to connect, how to connect, and the different programs that we all might be able to take advantage of during this time, wherever we are in that journey. There is a recording already on the AuthoriCare website from the first webinar, which I will say was extraordinary. So if you go, you can see the website, authoricare.org/knowing. The recording of that webinar is already there. Today's will be on the website as soon as it is prepared. And we keep a repository of all of the different recordings. And before we leave this space, I wanted to share a quote that really resonated with me and I think speaks to our conversation. And it says, "To love a person is to learn the song in their heart, sing it to them when they have forgotten." And that was said by Arnie Garborg. And it is true that we are all journeying together during this time. So thank you again to our panelists, to those who have joined us as participants, and we look forward to seeing you on August 13th at noon to continue our conversation. Thank you, and I hope everyone has a good rest of the day.